Greg cut himself on the saw. Can you call for help and wait outside for them till they get here and bring him back?
Okay.
Thanks.
Can I help with anything?
Yeah, could you get the first aid kit, please?
Yeah.
Thank you. Okay, Greg, try and elevate from here. Okay, try and keep your arm elevated here. Great, thanks. Great. Continue in your Thanks. Okay, Greg. Get this on here. One minute, Greg. Okay, let's have a look at this.
Control of bleeding is a basic but important first aid skill. By controlling a patient's serious bleeding, you can positively influence a patient's outcome. Serious bleeding is life-threatening because blood carries oxygen to the body tissues. The body holds about 6 liters or quarts of blood, and losing even one can cause death. There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessel and carry blood from the heart to the tissues. Arterial blood is bright red and spurts with each heartbeat. Arterial bleeding is the most serious because the patient can lose a lot of blood quickly. If a major artery is cut, death can occur in 1 minute if not treated. Activate the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark red and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the patient's cycle of care. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding tends to be slow and easily controlled unless the injury covers a large area. Monitor the patient's cycle of care and contact the emergency medical service if necessary. To begin helping a patient with serious bleeding, first assess the scene to make sure it's safe for you to approach. Put on appropriate barriers and deliver your responder statement, asking the patient if you can help. If the patient says yes, call emergency medical services. Reassure the patient as you treat for bleeding, and if needed, assist the patient into a position of comfort while treating. Since the patient is responsive and breathing normally, you can sidestep CPR, chest compressions, opening an airway, and breathing for the patient. With a responsive patient, proceed immediately to the S in ABCABS on the cycle of care. The first S in ABCABS prompts you to check for serious bleeding. To control serious bleeding, use sustained direct pressure. Put a clean cloth or dressing on the wound and apply constant pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. Maintain the pressure continuously, but you may periodically release pressure to see if the bleeding has slowed or stopped. In addition to sustained direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. The patient may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Applying sustained direct pressure and pressure bandages best controls bleeding. However, there may be regional treatment variations, such as elevating bleeding limbs, giving the patient oxygen, and applying a tourniquet as a last resort to controlling serious bleeding. Your instructor will advise you of these variations. Shock is the body's response to serious injury or illness. Shock can be life-threatening and happens when not enough oxygenated blood reaches the body tissues. This occurs due to serious bleeding or when the body no longer regulates blood flow to the tissues. In general, always treat an injured or ill patient for shock, even if the signs and symptoms for shock are absent. There are 9 indications of shock, though some occur with other injuries. They are rapid, weak pulse, pale or bluish tissue, moist, clammy skin, possibly with shivering, mental confusion, anxiety, restlessness or irritability, altered consciousness, nausea, and perhaps vomiting. lackluster eyes, dazed look, and shallow but rapid labored breathing. By the time you get to shock management, you will have progressed well along the cycle of care. You will have assessed the scene and applied your barriers. Through primary assessment, you would have confirmed the patient's level of responsiveness and that he is breathing normally. Since the patient is breathing normally, there is no need for CPR. If the patient is unresponsive or bleeding, you would have already alerted the emergency medical service. If he were bleeding, you would have treated him by applying direct pressure. To treat a responsive patient in shock, let the patient determine what position is most comfortable, sitting or lying down. To treat an injured and unresponsive patient, do so in the position you find him. If there may be a head, back, or neck injury, don't move the patient and keep his head and neck immobile. More on spinal injury treatment in the next skill. Regardless of whether the patient is responsive or unresponsive, to treat for shock, maintain the patient's body temperature based on the local climate. This may mean covering the patient with a blanket or exposure protection from the sun. If there's no reason to suspect spinal injuries or leg fractures, elevate the patient's legs 15 to 30 centimeters, 6 to 12 inches. This shifts blood to the more critical chest and head areas. Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. Moving a patient with a head, neck, or spine injury may make the injuries worse. Therefore, never move a patient with a suspected spinal injury unless absolutely necessary because of imminent danger. With a responsive patient, conduct your primary assessment where you find him. You would only move the patient to avoid immediate further harm, such as if the patient were in the water or a burning car or building.
Take it easy, okay?
You would also move the patient, if necessary, to provide CPR. You should suspect spinal injury with situations that cause injury to the head, neck, or spine. These include auto accidents, being thrown from a moving object, falling, especially from a height higher than the victim, a penetration wound such as a gunshot, any severe blow to the head, neck, or back, an accident that includes hitting something head first, such as diving into shallow water, lightning strike, or any severe impact injury regardless of what part of the body was struck. 8 indications that a patient may have a spinal injury are change of consciousness, difficulty breathing, vision problems, inability to move some or all of the body, paralysis, headache, vomiting, loss of balance, tingling or numbness in the extremities. For an unresponsive patient, start by assessing the scene for danger. Put on appropriate barriers if available, and begin to conduct your primary assessment. Conduct your assessment with the patient in the position you find her. Unless the patient's safety is in question, she might need CPR, or you need to control serious bleeding of a wound you can't see. Deliver your responder statement and have someone call emergency medical services.
Call for help.
The patient must be on her back for continued care. If she's not already on her back, you'll have to turn her while minimizing risk to her spinal cord. You want to stabilize the head and neck so that as you turn the patient, they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the patient all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you under her hip, and while supporting her head, roll the patient toward you. Gently ease the patient onto her back and continue with the cycle of care by starting CPR if the patient isn't breathing normally. If the patient is breathing normally, check and treat for serious bleeding, shock, and spinal injury. In a primary assessment, you've learned how to apply the cycle of care to ask 2 initial questions when someone is in need of emergency assistance. Is the patient's airway open, and is he breathing normally? When a responsive and conscious patient is choking, they neither have an open airway nor are they breathing normally. A choking patient needs immediate help to restore breathing. In adults, the most common cause of choking is food. Let's learn how to help a conscious and unconscious patient expel an object that's causing him to choke. If you believe a person is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive patient,
"Are you choking?"
If the patient is coughing, wheezing, or can speak, encourage the patient to cough until he expels the object. If the patient cannot speak or breathe, give the responder statement and alert emergency medical
"I'm an
services.
emergency responder. May I help you?" "All right, take it easy."
After the patient indicates he wants your help, a nod will do. You may use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. Techniques for handling a conscious choking patient vary internationally. Your emergency first response instructor will teach you the techniques appropriate for your area, and it's those you should use when assisting a choking patient. In general, however, there is no clear evidence that one technique is better than another, but there is evidence that if one technique does not help a choking patient, then another one might. To deliver back blows, take a position to the side and slightly behind the patient. Supporting the chest with one hand, lean the patient forward. Next, firmly strike the person between the shoulder blades with the heel of the other hand 5 times. Stop if the obstruction clears or move on to another technique. Abdominal thrusts use residual air in the patient's lungs to blow the obstruction clear. Stand behind the patient with your arms around her waist. Find the patient's navel with one hand. Make the other into a fist and place the thumb side against the patient's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the patient's ribs, pull your hands inward and upward in a thrusting motion. Stop if the obstruction clears or move on to another technique. Abdominal thrusts may not be possible with some individuals, such as those who are pregnant or markedly obese. In these cases, provide thrusts in the center of the chest.
"Are you choking?"
Use your fist with the thumb inward and the other hand on top, just as you do with abdominal thrusts, but put your fist on the same site where you would perform a CPR compression. Continue using one or more of these techniques until the obstruction is relieved or the patient becomes unconscious. When you practice these techniques, be sure to simulate thrusting. Never perform thrusts on a person who does not have an obstructed airway. If a responsive choking patient becomes unconscious while you are trying to help, carefully help the unconscious patient to the ground. Next, activate emergency medical services and immediately begin CPR, chest compressions. The compression should dislodge any obstruction. Following the chest compressions, you should quickly look inside the patient's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. Continue CPR until the obstruction is relieved and the patient becomes responsive or emergency medical services arrives. Depending on local guidelines, restrictions, or laws, your emergency first response instructor may be able to offer a skill development session on emergency oxygen use. Receiving adequate oxygen is crucial, especially after a serious injury or illness, near drowning and scuba diving incident, plus continued exposure to altitude. You can decrease patient stress and support the respiratory system by administering emergency oxygen. You may want to seek additional and more advanced oxygen training if you are a scuba diver or you frequent locations that offer aquatic activities. Now that you understand the 9 primary care skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts the cycle of care to the realities of the situation.
Grandma, are you okay? What happened? What's wrong? What happened? Hang on, everything's
Stop,
gonna be okay.
think, and then act. Is there a hazard here? The emergency responder sniffs for gas and confirms the gas stove is turned off. The caregiver delivers the responder statement and gets emergency care
Grandma,
on the
do
way.
you need help? It's okay, I'm an emergency responder. May I help you? Jimmy, come here quick. It's okay. What's wrong? I don't know. Something's wrong with Grandma. Go call for help. Tell them we have an emergency and then come back and tell me what they say.
I'll call and come back.
It's okay, Grandma.
The emergency responder monitors the patient and uses the cycle of care to guide her. She's responsive and breathing, so there's no need to provide CPR. Further, there's no evidence of bleeding.
Help will be here soon.
Help me put her in the recovery position. Put her leg a little bit forward. Go get the pillow and blanket on the couch. Go wait for the ambulance outside.
The emergency responder treats for shock and continues to monitor the patient until help arrives.
Be okay. Help is on the way.
The emergency responder stops, assesses the scene, thinks, and then acts.
Hey, this is Fabio, an emergency responder. May I help you? May I help you? Are you okay? Are you okay?
The emergency responder finds the patient unresponsive. His airway is open, but he is not breathing normally.
Hey, Sherilyn. This is Fabio. Listen, I'm in room 3. RF is down. He's unresponsive and he's not breathing. I want you to activate the company emergency plan. Then I want you to call emergency services and direct him here to room 3.
Using the cycle of care to guide him, he calls emergency medical services and immediately begins chest
1,
compressions.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 5, 6, 7, 28, 29, 30.
The emergency responder provides CPR until emergency medical personnel arrive.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17.
A medical emergency with more than one patient and only one emergency responder requires some thought. You can only do so much, so do the best you can. Stop, think, and then act.
Yeah, I need to report an auto accident on the corner of Alton and Pacific. It looks like you might have a couple injured passengers. Yeah. Yeah, okay. Sit tight, all right? Help's on the way.
The emergency responder approaches the scene cautiously, keeping himself safe and watching for hazards as he approaches the scene.
Hey, my name's Matt. I'm an emergency responder. May I help you?
Yes,
Well, where do you hurt?
on my head. I'm okay.
Okay, I want you to try not to move it, okay? Let's wait till the medical crew gets here so they can check you out. All right? It looks like your passenger may need some help, so I'm gonna go take a look at her. So just sit tight and relax, all right? I'll be nearby. Hey, how you doing? You okay? You all right? Just relax, okay?
The emergency responder uses the cycle of care to guide him and begins to treat this patient's serious bleeding. Notice that he continues to monitor the patient while maintaining continuous direct pressure on the wound.
How's your head feel?
The same.
Okay,
The
just relax.
emergency
Help's on its
responder
way.
asks this question of the first patient as a simple way of checking to see if he is still responsive and breathing.
Is there anything that I can do?
Are you a trained emergency responder?
No.
That's okay. You know what? You can put on this extra pair of gloves I have here.
Okay.
Try and lay still, okay? Keep your head still for me. What I need you to do is I need you to put pressure on this wound here, okay? If you need another bandage, go ahead and take one out of that box and put it right on top of this, all right? Keep pressure on the wound the whole time. Okay, so when I take my hands off, go ahead and replace them with yours, okay? Here we go. Good.
The emergency responder continues to use the cycle of care to guide him and monitor both patients until the emergency medical service providers arrive.
There you go, lay still. Okay, keep pressure on there.
Okay.
Okay, try and relax, okay? I'm gonna hold your head until the ambulance gets here.
All right.
Sit tight, all right? The guys are here.
How many people do we have in the vehicle? One?
Just two.
Two, that's it. Anyone ejected? Anyone else in the vehicle? No?
Came on these guys.
No, that's it. Okay, what do you have right there?
As you saw, having more than one person at the scene increases the aid available. By encouraging your family and friends to complete the emergency first response courses, you increase the chances there will be more than one emergency responder at hand in a medical emergency. As an emergency responder, you play a crucial role in a medical emergency. In life-threatening emergencies, you provide the critical first links in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Most emergency responders will never need their skill, but practicing them and reviewing this program will help you be ready to reach out and help another in need should you ever need to.